Good day, everyone. At the outset, we would like to invite you all for this virtual program organized by Savita Oral Cancer Institute and Reconstructive Surgery of Savita Dental College and Hospitals with the support of Dr. Elena, Co-Director, Microsurgery Research and Training Laboratory, Department of Orthopedic Surgery, Columbia University, and also with the support of AOMSI, Tamil Nadu and Pondicherry Chapter, and International Microsurgery Simulation Society. Ablative surgery has become an integral part of oral and maxillofacial surgery as the incidence and prevalence of oral cancer is tremendously increasing in the South Asian subcontinent. Resection in oral squamous cell carcinoma, though being an intricate procedure by itself, reconstruction of the resultant defect is even more challenging. Reconstruction using microvascular anastomosis or free flap is considered as gold standard in restoring the form and function of the oral cavity. Flap harvesting and coaptation of the vessels are the two phases of reconstruction. However, coaptation, that is microvascular anastomosis, predominantly determines the surgical outcome. The delicate handling of vessels, like connecting the feeder and the recipient vessels with the help of microscopes, enhances the surgical outcome. This nuanced surgical technique requires intensive training. Let's get some inside secrets about the training and clinical application of reconstructive microsurgery from Dr. Elena, who is a research scientist instructor in clinical microsurgery, co-director Microsurgery Research and Training Laboratory, Department of Orthopedic Surgery, Columbia University, New York. She has several publications, certifications, honors, and presentations to her credit, and it is our pride to be associated with Dr. Elena Madam for this program. This program is being moderated by Dr. Sendil Murugan, professor who is working in Savita Oral Cancer Institute and Reconstructive Services of Savita Dental College and Hospitals. Now, let me hand over the mic to the moderator. Thank you.
Thank you very much.
Can you hear me?
Yes.
Thank you, Dr. Elena, for having spent so much of effort in sharing the treasure of knowledge with us. And as Magdi is clearly mentioned about the prevalence of tremendously increasing prevalence of incidences of oral cancer in the South Asian population, and India hails 30% of population is being affected with oral cancer. So the free flap surgery has become integrated part of this oral cancer reconstruction. So as she mentioned about the role of microvascular anastomosis, the coaptation predominantly plays a major role in determining the success of the outcome of the flaps. So this main objective of the webinar is what to be done prior executing on the patient. That is what it's purely a preclinical training program. Each and every maxillofacial or microvascular surgeon has to undergo prior their execution on the patients. So all the flaws which has to be overcome at this point of time off the table, and the patient can be handled very confidently at the end of the training program. So now, once again, I thank Dr. Elena for the association with Dr. Elena is almost a decade, and she's the one who introduced myself to the international peer. So she was so modest and broad-minded outlook. So with this, I thank and acknowledge gratefully acknowledge Dr. Elena's contribution for this webinar. Dr. Elena, please start.
Well, thank you very much. Thank you, Senthil. Thank you, Dr. Nirala. It's a pleasure for me to be here, and I'm looking forward to share my experience and my knowledge with all of you. And let's start from the beginning. If you have, guys, any questions in the chat, there is a link that you can click and post your questions on the special form that we can try to answer some of them during the lecture, and some of them after, and some of them I'm going to individually reply to you if there is some more serious questions. So I'm going to share my screen. Well, and I'm going to talk about, so a couple of words about me. My name is, Dr. Yelena Akalina. I work in the Department of Orthopedic Surgery, Columbia University, New York City. I've been working here for a pretty long time, been teaching microsurgery for the last 25 years. And joined a lot of society. I'm going to talk about this in the slides, but I'm really glad that we're doing this in behalf of society that we organized some time ago, almost 10 years ago. It's IMSS, International Simulation Microsurgical Society. Centil is a big part of that, and it's a network of educators in microsurgery, and they support this webinar as well. It's a really nice networking community. So we're gonna have, I'm gonna share my screen, and the idea for this webinar is I'm gonna introduce you basic aspects of microsurgery from the very get-go, from the very beginning. So people who are joining us as the medical students or residents in the beginning of their training, I'm going to go a little bit and very basic aspects, what microsurgery is. And then I'm going to say, what is it we do, how we teach that here at Columbia. And then we're gonna say a couple of words about the basic, how we start teaching. So idea of this webinar is the beginning of the virtual series of hopefully trying to get people learn from us virtually. Unfortunately, with this pandemic that going on around the globe, people cannot travel. And the need in training and education, it's always been pretty great, and now even bigger because the education is very limited to unfortunately only virtual training. This is this webinar is a first one of the hopefully a series of virtual webinars, and we're going to go into details a little more later on how we can try to do that. All right, with this, I'm going to start sharing my screen, and we're going to get into the presentation for my talk. So again, this is the basic aspects of reconstructing microsurgery, and I'm really happy to invite you to my lab, which is now located in New York, and you'll see more of that soon. So I would like to thank again and acknowledge a big deal of Savita University inviting me and organizing this beautiful webinar. And hopefully it's a beginning of a nice relationship between Savita Dental College and Hospitals and Columbia University Department of Orthopedics Microsurgery Lab. I would like to personally thank you, Dr. Deepak and Dr. Murugan, for putting a lot of effort to making this happen. Thank you again, and hopefully this is a nice beginning. So as of me, I am a veterinarian by training. I have a DVM and a Master of Science, and I finished the Moscow Veterinary Academy and started working at Columbia University in 1996. I teach about 200 surgeons a year from about 60 institutions from US and about 70 countries. We have a lot of people. This is why internationally teaching these webinars is very important for me, because this is how we used to have every week people coming from a lot of countries. So I'm an active member of American Association of Reconstructive Microsurgery, World Society of Reconstructive Microsurgery, IMSS, which I already said, RAMSES, it's a robotic assisted microsurgery. ISEM is the experimental microsurgery society about people who is doing a lot of transplants. We do also not only teaching in this lab and a lot of research in hand and plastic microsurgery. So what is microsurgery? From the very beginning, we can say the microsurgery is the surgery that performed with assistance of the stereo microscope, micro instruments, and microsutures. So surgery that usually allows people connect the vessels and nerves 1 millimeter or smaller. We are using from 8/0 to 12/0 nylon or different sutures, which is very small, and a special micro instruments. Microsurgery is a skill, and it's used in a multiple medical practices and procedures. And this is a short list of the specialties that use in microsurgery for their procedures, like digit replants, cornea transplantations, reversal was vasectomies, different flaps, and different reconstructive microsurgery that's used in maxillofacial and dental plastic surgery. So this is more application for the dental and maxillofacial surgery. And I think most of you guys who join us here because Centil invite is connected to the specialties. So I'm not gonna go into details. You're all familiar with all of this. Procedures and defects that will be treated with using of microsurgical skills. Microsurgery is very difficult and very challenging. It's, as I said, it's a surgical skills and need to be taught. So you can walk in the OR with a patient on the table and perform 1 millimeter diameter vessel. So it is difficult. It has to be dealt in a controlled environment. And why is it so difficult? Because it's very different. And the most difference is because it's a different tissue handling. You're handling a small, fragile tissues of the vessels and nerve, which is 1 millimeter or smaller diameter. You concentrating on the small details of surgery, and all small details are very crucial. So it's very short margin of errors in microsurgery. If you've done one little thing and everything can go wrong. So you're learning to do eye, hand and foot, and hopefully brain coordination. A lot of my students saying that everything is here. So you do have to control everything that you do under microscope is your brain. You have very fine and small hand motions. This is the big difference from the bigger macrosurgery when you're moving your hands and you're moving your body and head without even thinking. And the microsurgery, we're all confined with the microscope, with the binoculars. You are really immobile. You don't move, and it's easily fatigued. So you have to learn to do that and practice that you know and prepared. You also have to be very well self-controlled and have a lot of patience. And we know the surgeons are not big on that. So learning that skill is extremely important, and it could be very frustrating. And I call it as a vicious circle because you're becoming frustrated and you're doing worse. And you're doing worse, you become more frustrating. So it's like a circle. So if you prepared emotionally and that it is a learning curve, that you know it's a learning, that you don't get too frustrated. Healthy frustration is okay, but if you understand that, you will do much better and you will learn the self-control. So life is interesting, and I'm going to show you a funny video that I recorded in my lab last year from one of the surgeons, and you will see why lab is needed to be taught for microsurgery before they go in operating room. So look at this. Unmute this.
Very fun. But the anastomosis is patent. That's the most important thing.
You just have to go with the clump. Just sew it up.
Oh my God.
So you see, this is what happened. And as my late father said, everything happened for a reason. So you have to do mistakes to learn. And this is why mistakes like that better to be happening in a lab, in a controlled environment. And I think everybody's laughing now, so you understand what happened. So how to overcome the challenges? hard work and practice. And you know, when you teach your kids, practice makes it perfect. This is exactly why the lab exists. And this is why we are doing a lot of work to teach people here in a less stressful environment with a full-time dedicated instructor using non-living models and dedicated time. So the course here, people do only learning microsurgery with no clinical responsibilities. So this is very important. Now, we have set our goals for our training. And this talk that I give a lot of times around the world, this is my motto for teaching people from all these 25 years. You become a better surgeon after completing the micro course. No matter what specialty you are, no matter if you will never do microsurgery in your life, you will be a better technical surgeon after completing courses like that. I truly believe that. And if you read the testimonials from people from my courses, from all over specialties, about 12 specialties happening here. So they all saying that. That's very important. You will listen to testimonials of my students in a while. And if you can see the goals of our training is exactly echoing the difficulties people experience while learning microsurgery here. So we're teaching them to how to gentle handle and dissect a very fragile tissue of the vessel and nerves. We are teaching them how to perform proficiently microanastomosis and peripheral nerve, which is 1 millimeter or less diameter. You're learning during this course how to pay attention to small details that I said it's very difficult and very important skill of microsurgeon. You're obtaining hand, eyes, and foot coordination, and hopefully brain. You're learning how to problem solve and decision making while working in a microscopic environment. So meaning that people are making mistakes and we appreciate the mistakes. We observing everybody, what are they doing wrong. And my philosophy of teaching, you better do mistakes in the lab so we recognize what you've done wrong and how do we what do we do to fix them? So you learn the confidence as a surgeon to be able to address mistakes in the operating room. Do not panic and know what you've done wrong and how to fix it. You also learn how to control your patients, and your self-control is very important. And I also put people get people understand that quality of techniques are more important than the timing of the surgery. You will get faster if you get comfortable. So learning microsurgery usually goes slowly and then speed will increase. So not an opposite, okay? So you better be a little bit slower than good than fast and bad. So something like that. So this is, again, as I said, we teach people from all over the world. This is just a few surgeons from different countries, and just to see from every continent. And they become my friends. Most of them I keep in touch. So now this is the basic microsurgery course that taught at Columbia University. And this is a weekly course. It's a basic microsurgery, most important one and most popular one. It's 1 week, Monday through Friday. It's about 8 hours a day. And we learn how to start with the basic knowledge of the surgical microscope, how to work with this machine, and how to tie nuts under microscope with the small instruments and small sutures. And starting with the living models, we start doing end-to-end femoral arterial anastomosis, different techniques, forehand, backhand, one-way ups when you're doing posterior wall first and closing arterial wall last. Then we're doing the femoral vein anastomosis, again, different techniques, interpositional vein grafting, different end to sides, and peripheral and sciatic nerve. This is the pictures of procedures performed by my students. and you can see whatever I mentioned from the end-to-end anastomosis to peripheral nerve. The main goal for students to get here, not only check mark of doing everything, but doing everything patently. So everything have to work. So if it doesn't work for technical reasons, we evaluate that, we see why is it not working, and the student doing it again until he will achieve the pretty much perfect anastomosis to move on. So I don't do checklist. You have to complete everything. You have to make it work. And this is important. The quality of training is very important for us. So the basic setup. So I'm gonna go over this briefly. We're gonna share the screen in a minute with my phone, and we're gonna show you what we have and how to perform a couple of stitches under microscope. So you will see, so we have a stereo microscope that it's an older model, but I can't fit the newest microscopes here in a small lab. It's a Zeiss microscope, the old stereo and OR quality. We have a plastic board, if you see, that have a plastic, the latex glove set up, and you have a tubing and a microscope, microsurgery instruments. So this is the lab that you can see how it's set up here, so you will understand what I'm talking about. We have only 3 students in a lab, which I really proud of, because we have a small group, ideal for one-on-one training. As I said, it's very difficult. So it's easier to do one-on-one with a small group. And if you can see, all microscopes are connected to the monitors. So I could, standing in the middle of a room, I can actually see what students are doing and give them suggestions or advice or critique without being there on the microscope and get them nervous. So they all have a high quality instrumentation. Now here they work on the live animals. We're using rats, and we're using femoral vessels of the rats. So they all covered for the ethical purposes for this video. So we start with with the latex gloves, and then they're moving to the live animals on the first day. So it's pretty quick rotation. And if you see they're doing, it's probably 3rd day, so they're all working on end to side anastomosis is using 10-0 nylon and small microsurgical instruments. So they all from different countries, and we will hear from them after they complete the course. I'm gonna fast forward this video. I think you got an idea of this. So we start with the body posture, and it's very important that when you sit under microscope, you're gonna sit straight, and you're not using your neck, and you're you're using a comfortable chair, which have to be adjusted, and you're using your hand position on the surface. So hopefully if you are working sitting, your hands have some support and they're more sturdy. And we're using the micro instrument, and this is the glove. So you can see that people are, my assistant sitting here posing how you have to sit correctly. So now we're gonna switch to the microscope. First to the iPhone, I'm gonna show you live how to do the posture and adjusting of the microscope. So now, so Kathy, my assistant, is switching to the phone so you can see it. So I'm gonna adjust my chair so I can sit straight with my back straight and my head looking directly, so your neck is not straightened. So you're not bending your neck, you're not pulling it, you're sitting straight. Your hands on the surface, so they're sitting like this. And she can zoom in a little bit on my hand position. You're holding instruments pencil grip like this, and the hands on the surface. Okay, so this you adjust the hands so they're more supportive and they're not moving, so you have less tremor. Now, if we look at the instruments, we will use the surgical needle holder. We can use angle jewelers. Perfect. So both of the instruments can be used as the needle holders, both of them. And in my left hand, I'm gonna use the straight jewelers, and I have micro scissors. So these 4 instruments for now, I'm gonna use to demonstrate the surgical, so how we start with the suturing technique. Kathy, can you show the board? So we have the plastic board and the small glove that attaches to the ring that rotates. So you can practice different angles for your angle of your wrist. So this is important. As surgeon, you should be able to do a different hand motions, right? So we're gonna start with the normal position, and we're gonna start with 9/0 nylon, and I'm gonna show you through the microscope from the very beginning. So this, you will understand how I...
Oh, Elena, they said that they can't see the posture. If you guys can go to the multiple viewing.
You're muted.
No. I'm just talking through.
Okay.
The multiple viewing. So there's a speaker view on Zoom, and then there's also a multiple panel view. If you look also on the Yelena iPhone video, that's where we're showing her posture, the positioning. So we are projecting video on both the Yelena Akalina and Yelena Akalina iPhone.
Can you see now? She can demonstrate this again. So one view you can see from the scope, this one, and one you can see from my iPhone that is outside the microscope. Can you see? It's getting done. Okay, so Kathy, with your iPhone, you can step back a little bit, maybe more. So you can see my posture, maybe from the side. Okay, great. Now, let me go very quickly about the adjusting of the eyepieces for people who have a very little knowledge of using the microscope. So what's important is focalization of your view when you're looking through the eyepieces, which you adjusted already with your magnification, with your binoculars and your intrapupillary distance.
Sorry to interrupt.
Yes.
Can you zoom better? Many of the participants are not able to view this.
Zoom in what?
Multiple use not. Yeah, it's something with the podium actually.
Okay.
With the platform that has been provided, because multiple screens are not getting open.
Okay.
Meanwhile, it has to be zoomed out. It's over focused actually. We can make it little central.
Okay, I think that if
The dry cut can be made little in the middle. The white part is out of focus.
I don't.
Wait, try talking now.
Why is it better? Okay, people are asking how to adjust the microscope. So the microscope adjustment, let's go over really quickly. So but the microscope has a focal length, which from the lens to the board, to your surface that you're working on, that's called focal length. So mine is 200. So, and I have a pedal underneath of the scope, which I can control with my foot. So I can bring the microscope lower or higher using this pedal. So if you see, I can move the microscope here and microscope here. So if you look at the, you'll see the microscope goes down or microscopes goes up. All right. So you have to be within a 20 centimeters zoom focal length to be able to focus. And then you're going to zoom in. So you can look at my screen where the microscope is, and you can see that I'm zooming all the way in on the highest meg, losing focus. And then I'm going to focus it, being on the highest magnification. So if you understand what it's called, porfocalization of the field. This is very important. So you zoom all the way in on the highest magnification, adjust your focus here, and then you can zoom out and you're still gonna be focused. So this is the #1 rule of any microscope, no matter what are you using. So you porfocalizing your view is a #1. You zooming all the way in on the highest magnification, and then you adjusting your focus on the high mag. Okay, I think that's clear, right? And then you don't really focus anymore. You just zoom in and zoom out. So on the view of the scope, you can see, I'm going to show you a stitch, how I start my training on my normal microsurgical course. Just type that you can see it well on my chat box. I'm looking at the chat. And if everybody okay, just we will move on. So this is 9/0 nylon. And I can use the needle holder that probably more familiar to all. And if you can see that I using the needle, the suture, not the needle, to load. So this is what I do. You need 90 degrees. So again, you're using the suture, load the needle. You need 90-degree angle. And this is a 90-degree angle entering. I can zoom in a little bit maybe. In a scope, put it in the middle of a screen. Okay, so in a microsurgery, we do not do this. Like you're grabbing this, the tissue when you're entering for the bite. In microsurgery, if we put this forceps underneath and you take a small bite, this is how we start practicing, okay? Small bite, which is 1 or 2 diameters of the needle from the edge. And you're gonna do the same thing on the other side. So it's a little bit too tight on the glove. I'm adjusting a little bit more the tissue. Yeah, glove is a very rude model for practicing, but it's working fine for the beginning. So small bites, again, lift up on the tip of the needle, push the needle all the way through and pick it up with your dominant hand. Do not ever touch the tip of the needle. Use the shaft, grab it and pick it up. So I'm gonna zoom in, zoom out. So the motion of the instrument is this. So small pronouns like this. Rotate a little bit and then I move in, put it in, and use the pretty big loop to tie. We're gonna use 3 surgeons, 3 square knots and 1 the surgeon knot to bring it together because it's just a lot of tension in the beginning. And soon, as long as the tissue meet, you're gonna stop pushing it together. I'm gonna see, I'm using the big loop so the instrument moves around it without disturbing your anastomotic blade. 3 square knots, that's all it takes. All right, I'm gonna zoom out and I'm gonna use the micro scissors to cut. I usually cut the short one first and cut the long one last, and that's your needle back. So you don't have to go look for it. So this is the basic suturing. So sometimes I use this instrument as well. And what I'm gonna do, so this exercise is teaching you to work with your foot and your hand and your eyes. So you load, then you zoom in on the more higher magnification that you can see much better the field. I'm trying to arrange that so you can all see in the middle. This is on a much higher magnification. You take the bites here. Oops, sorry. So you take the bites. And when you're taking the needle out, you're gonna zoom out together. So you can visualize more of the field. So this exercise is teaching people to adjust to the pedal and they work with the hand and the eyes together. So this is very important because we're only using pedal control for zoom and the focus. And this is what people need to do when we start doing the live models, so they're familiar with the pedal. And I cut, and this is we're done. So this exercise we do in the beginning of our course. How we do switch to my camera so they can see me. And this is how I start teaching. For this exercise, we use about a few hours. So people are zooming in, zooming out, using those plastic glove and the small sutures. So this is beginning of our training. If you have any questions concerning this, this is good.
One is while placing the knot, you keep that needle away from the field of vision, or you want to retain the same place so that you can identify the needle earlier.
If
While
I'm
placing the knot, you've taken the bite on both edges. For placing the knot, will you place the needle close to the vision, I mean the field, or you want to take it away and keep it outside?
I'm zooming, so I'm loading the needle on the low magnification so you can see better, and you're using your hands much better in the beginning on the low magnification. Then I zoom in to take the bites, and with every stitch I'm going higher and higher on magnification. And then when I place the bites on the high mag, then I zoom out to pull and tie, because you do need to see the end of a suture, otherwise you're going to pull it through. So we're basically zooming twice on each bite. Do you want me to repeat the stitch with all of this technique?
No, this is enough. Just a few doubts that we have that. And is the one question from the is the knot
seated on one side? No,
the knot, yeah.
The knot sits usually in the middle, but it's a surgeon's preference. You can put them on one side or not. It's really not that important. I put them in the middle because when we suture the vessel, it has to be on the middle.
How about the type of the needle? You want to choose the spatulated, or you want to use the round body needle?
No, we're using taper cut needle. Is it 9/0 needle, 9/0 nylon taper cut, well, 3/8 of the curve. And it's 135, I guess, 135 degree curve. This is 9/0, so it's 140 micron length. In a rat, we're using 10/0 with a 70 microns length. So we're gonna move on with the presentation. I'm gonna.
Also, someone asked a relevant question.
Yes.
What milestones do you use to decide if someone's ready to go from this non-living model to a live rat in training?
Well, I use my judgment. So if person is comfortable using the microscope and easily using 9/0 and instruments, so I can judge by seeing them. So sometimes we use the chicken model. If people are struggling, I can see they either not comfortable with the instruments or the hand motion. So we use the chicken before we go to the rat. So there is, this is my personal judgment. So there is not really something that I can objectively, it's all subjectively decided by me personally. And again, it's a small group. It's only 3 people, and I can see if person is ready to move on, and usually they are. It's possible to use this under surgical loops or surgical microscope is mandatory. Well, what I teach is all under microscope. The glove, yes, you can use with the loops, and you can use chicken with the loops. We're going to show that a little later. Yes, you can use your loops, but the models that I'm using live is 1 millimeter diameter. You will not be able to see it with the surgical loops. So microscope is, yes, mandatory for the live models. All right, so we're gonna move on with the presentation. We did this. Oops. And we're gonna go into the microanastomosis. So this is how we start on the rat. So by the way, everything that I do is on the videos. So we have an intensive video library, which is actually on YouTube in the Columbia Orthopedics YouTube channel, and you're welcome. It's all free. You can all enter the videos and see that if you want to learn from those videos as well. So if you can see, this is part of the video, and I'm gonna also go through it really quickly. So we clamp the vessel. We're going to identify 12 o'clock and 6 o'clock and put the stays sutures in there. And we attach those stay suture to the clamp dividers. And we're going to bisect this distance in half and then put one extra stitch on each side of the 3 o'clock stitch. I'm going to show you all of this on my anastomosis video. So what's going to happen, we're going to, I have the video that I told you on the YouTube, and I'm going to just narrate this. So I'm going to basically talk over my own video. But this video, again, is available on YouTube, and you can watch it on your own. But this, I'm just taking you step by step through my course. So this is how you are basically, all of you, participating on my first day of the basic microsurgery course. So this is just a small illustration so you have idea what we're doing. And we're going to go through the video in the beginning, from the beginning of the dissection. So this is simple artery anastomosis, which is done by me here in a lab with the help of my interns. So again, this is, you are participating in my course, and this is how we start with the simple artery rat model on femoral end-to-end anastomosis. So we begin with the dissecting femoral artery from the femoral vein. And if you can see, it's done under high magnification. And the first one, we're separating 2 vessels from the perivascular sheath. So you're separating artery from the vein. And what I'm showing is the grip. So how you grip the vessel, you grip none of the tissue, you're only going through the adventitious. You have to be very careful with the branches. There are some branches underneath of the vessel, so you have to be ready and visualize them. I put a little bit of lidocaine or bupivacaine, whatever you have as a local anesthetic, and also as a vasodilator. So after you visualize the branches, we are ligating the branches. We call it Murphy branches. And this is 10-0 nylon, and it's ligated thoroughly. And you see how I'm lifting the vessel up so you can see where your ligature coming. So it's very important. So you have a space to coagulate the branch after. You stay away from the artery, from the vein and the nerve, and just coagulate it with bipolar. And then you cut, and the vessel is freed up. Again, this is 1 millimeter diameter vessel. So the loops are not gonna make it happen. You need the microscope on that. So we are place a background to protect the vein and have a contrast for the vessel for the suturing. It's much easier. And then we bring the Acklin approximator clamp. I'm using this clamp for teaching purposes that has a frame around it. And we use this for pretty much every vessel that we anastomosing. So you're gonna see how I'm applying it. I'm not gonna excise the branch because it's kind of sitting more proximally. So this is epigastric vein on your left and inguinal ligament on your right. So inguinal ligament is a proximal end and the epigastric vein is the distal end. So we ensure that the vessel have some slack in between the vessel, between the clamps, and we're gonna cut it. And as soon as you cut, you are gonna heparinize it. So I'm using 10 eye surgery cannula with a 30 gauge needle. So it's polished, so it could go inside the vessel. It doesn't have to be, but it could go inside. So you flush, make sure there is no blood left, and then we're gonna trim adventitia, which is very important. We do it under high magnification and under the water. And if you can see, it's much easier to see if you have water in the field. So it kind of floats and you can see the vessel being trimmed by adventitia with a good visualization of the adventitia. It's very important. So you have to keep the vessel underwater and you have to keep the scissors parallel the surface you're cutting from. So if you notice how I position the scissors, so they will not injure the side of the edge of the vessel. So this is very important trick to remember. Keep the scissors always parallel. You can always do this also. You can rotate the vessel on the side of the clamp, but be pretty careful. And again, notice the position of my scissors. Now we dilate the vessel with a vasodilator a couple of times just to have it open. And so it's basically just a couple of times with the ends, so you see the vessel is standing up much more clearly to visualize that. We're gonna bring the approximator clamps together to have less tension between them. And I do that just before I start suturing because you do need some raise the hands. So if somebody raised the hand, it's better if you can post the question in a chat box and I can answer it. So now we place the 12 o'clock stitch. Why should adventitia be excised? So adventitia does need to be excised. Let me pause for a second because you don't want anything to be brought inside the lumen. So you're only trimming adventitia that can be slide over the lumen edge. So with the needle, you will not bring that piece inside the lumen that will cause you thrombosis. Very important to trim adventitia that can be slide over. You do not over trim it so the wall become too thin. Did I answer your question? Hopefully I did. So adventitia trimming is important. All right, so we're gonna continue. So I'm gonna put the 12 o'clock. Let me rewind a little bit. So see the little trick that I use. Look, I grab the 12 o'clock and I rotate it slightly so I can go between the teeth of my jewelers for support. So this is very important. So somebody else raised a hand. So I replace this again. You can rotate the 12 o'clock for support and you support metal to the metal. Do not do metal through the tissue, so the hole that you enter are staying small. Metal to metal, needle to the pickup are very important points to remember. So you're using both hands to support. So somebody raising the hand, let me stop for a second and see What question they asking? Scissors are kept parallel to cut the end of the vessel. Is it possible during last suture? Possible what? Yes, you can cut, you can keep the scissors parallel to cut the end of the vessel. And I'm not, I don't understand what's possible during last suture. Ray stated more clearly what exactly the question is. So let's me move on. Let's close this. So let's me move on. And so the 12 o'clock on the other side is on exactly the same position. And we're pulling over, and you can see I'm zooming in and zooming out. Remember the question was, are you needing magnification? Centil was asking me. Yes, I'm taking all this bites, initial bites on the highest magnification, and then I zoom out to pull and tie this the suture so I can see. Visualization is your main work, is very important to visualize everything that you do. Otherwise, you will not be successful in microsurgery. Now I'm placing the 6 o'clock stitch, and it should be exactly in the 6 o'clock position and could be tied up to the other side of the frame. So adventitious initial coaptation.
Does it induce coagulation? Is asking.
I'm sorry, what? Say it again, Cynthia.
Adventitia, does it initiate coagulation? That is the question. If you don't remove adequate, adventitia, does
Yes.
it cause coagulation? Coagulation of the blood which is entering in.
No, removing adventitia will not cause thrombosis by itself. No, it will not. But if you don't remove adventitia and bring it in with the needle inside the lumen, that will cost you thrombosis. And adventitia transparent. The problem is that you won't be able sometimes to see it. Please give a maximum number and minimal number. So for the successful anastomosis for 1 millimeter diameter vessel, you need 8 stitches, 8 sutures. This is ideal for the 1 millimeter, okay?
Yeah. So how far we can excise the adventitia, the extent of removal of the adventitia from the lumen end?
Only something that can slide off. Something that you can slide off the vessel have to be removed. Only from the suture line, maybe a millimeter.
Yeah.
This of the edge of the lumen.
Does it have any role in that? If I remove extensively, if you completely deglow, completely remove the adventitia, maximum of 1 centimeters, for example, does it have any role in that?
Well, my thing is on this. There is different opinions on adventitia removal. From my understanding, if you remove too much, the wall becomes too thin, and every time you enter the lumen, you're gonna rip it. So you're only trimming adventitia that again they can slide as the sleeve from the edge of the lumen. You do not remove the rest of them. You don't need it, because the wall again becomes so thin. Every time you take a stitch, you're gonna have a hole. Okay. So now, yes. Anything else?
Yeah. Please continue. Please continue.
So we're doing the 6 o'clock stitch. Now we're gonna do the 3 o'clock. We're dividing this distance in half. And you can see how I lifted up with the tip of the needle. And sometimes you can see inside the lumen that you didn't grab the back wall. So I can keep one end a little longer because we're using it as tag. We're lifting wall up. So basically it's preventing the back wall. So we lift the vessel up, and if you can see, I put the needle halfway through, I flip the clamp, and I can check if the walls are not affected. So I didn't grab any back wall. I did the needle through and tied up.
The distance between each sutures to prevent micro leakage after releasing the clamp.
The distance, it's about, well, it depends on the size of the vessel. So here probably maybe I'll say a 0.5 millimeter. I never really measure it, honestly. So, but if you put even stitches evenly, then you can see the distance. Also, when you're taking courses like this is what you learn. I can't tell you exactly the distance because the vessel could be different. So I would say 0.5 millimeter. You can see on this vessel what's the different distance is. So now we flipped it over, we finished the front, and now we're finishing the back. So now 9 o'clock. So checking the back wall stitches are very important. It's crucial actually. So sometimes I can leave the 9 o'clock on the back open to prevent the back wall also. So now you can see I'm lifting the wall to avoid the back wall. Small bites, 1 or 2 diameters of the needle from the edge is very important. So now anastomosis is done and we remove the clamp. So you always remove the distal part, the slowest blood pressure first, and then you remove the proximal end. We usually use a Q-tip, or I'm sorry, the fat pad on anastomosis, and it helps. I did the research a while ago. It helps prevent the bleeding time, decrease the bleeding time in 50%. And now we perform the strip test and lift up test, and you see the patency. So anastomosis is done. So on the next video, I'm gonna quickly show you the work we've done with revision. So if you open the vessel and, we're not gonna do one way. So if any significant angulation of taking suture bite, 90 degrees, you have to go with 90 degrees the vessel to the side of the lumen. So 90-degree needle to the needle holder and needle to the entrance of the edge. Difference between artery and vein preparation. Veins are much more thinner. You have to be more gentle, and it has the much bigger branches you have underneath. So you have to be just much more vigilant, and you have to be much more careful to prepare with veins. Do you use Eklund forceps? Yes, you can use just the forceps stripping vessel distally and releasing the one close to anastomosis to see the blood going through. 9, 8. Well, it really depends. So what I said, 8 stitches because we're using 1 millimeter diameter. So you can, if there is a bigger vessel, you will be judged how many stitches you can put. So 8 stitches is enough to complete 1 millimeter. If you have 2 millimeters, it could be 10 or 12. It really depends on the size of the vessel. So if there is maximum time limit to complete anastomosis, well, not really. Well, I'm talking to you about training. So in here, sometimes people use about 2.5 hours to complete the first anastomosis, and it's working. So it's really not in a clinical setting. Of course, you're gonna do it as fast as you can, but you do have to be good. So technically, you have to be
Fast.
mastered.
Yeah,
right?
fast.
I'm sorry, what?
Yeah, that's what he's asking. How much time you can take to do anastomosis so that reduces the flap perfusion. They can restore the flap perfusion earlier. That's what he's asking. Is there any maximum limit to complete anastomosis? Time for anastomosis?
Well,
You said 2.5 hours.
Well, yes.
You said 2.5 hours, right?
No. In the beginning, people take sometimes people can do about 2.5 hours. I can do anastomosis in 10 minutes. So people leaving the course, microsurgery course, able to complete anastomosis 1 millimeter diameter within a half an hour. Half an hour, 40 minutes. I would say this is a good timing to complete anastomosis to avoid thrombosis. Prolene and nylon, I'm using nylon. Any continuous suturing, no. So the vessel 1 millimeter diameter, we're using interrupted only, and continuous suturing is very hard to do on this small vessel because a lot of things can go wrong and nothing much you can do to fix it. So basically you have to start over. So if you're really good, you can do running, but I will not suggest that. Most of microsurgeons do interrupted suturing on the small anastomosis. How to check the patency? We use this strip test. Strip test or fill up test. So you basically, if you lift anastomosis up, we just showed you, or you can lift it up and you can see the vessel pumping. So you can see, see, look at this. We can just demonstrate. You see this? This is the lift up test. So you can see the pumping, and this is strip test when we occlude the vessel and just see if it's working. Where is the Q-tip? Is it here?
It's the next one.
It's one way up. We don't need that. Okay, so now I'm going to show you how to revise when you complete the anastomosis and you open it up and it's bleeding. I do not clamp. I don't put the clamp back to revise it. So what we did actually a research with my interns, and we did a partial occlusion repair without the clamp. I'm going to show you a quick video that my intern put together for the novel technique to perform the vessel anastomosis revision. This is their work, and I let them speak.
Imagine this scenario. You've just finished your anastomosis when you come across this disaster. Your artery is leaking everywhere because your suture placement is uneven. We told you not to drink that extra cup of coffee this morning. Conventionally, bleeding that does not settle within a few minutes requires the surgeon to reclamp the vessel and place an additional suture. The problem with this method is that clamps completely occlude small vessels, making it difficult to pinpoint the leak site and ultimately increasing the chance for developing thrombosis. We developed a clampless method that partially occludes blood flow using a cotton-tipped applicator while an additional suture is placed to revise the leak. Here, we're demonstrating our novel technique to perform microvascular anastomosis revisions without clamps. With the use of a moist cotton-tipped applicator placed under the artery, briefly lifted until the flow is completely occluded. We then irrigate with heparinized saline to clean and gain visualization of the suture line. By gently lowering the cotton-tipped applicator, we are able to partially occlude flow while still allowing blood to continue through the artery. Continuous drops of heparinized saline helps identify where the suture needs to be placed. Notice how if clamps were applied during this revision, there would be no flow, making it more difficult to locate leak sites. Once our location is found, we place a suture at the leak. It should be noted here that continuous blood flow keeps the artery inflated, which decreases the chance of inadvertently placing a back wall stitch. One can then lift the tails of the suture to temporarily approximate the arterial ends of the leakage site. If the suture placement is correct, the leak should stop and we're ready to tie our knots. So why is this technique important? Well, the primary reason our technique is relevant is because it maintains controllable and continuous flow that enhances visibility of leak sites, making it a safe and effective alternative to using vascular clamps. And our data proves this belief. We performed a research project at our lab to evaluate the safety and efficacy of this clampless revision technique. And overall, our study found that 147 out of 184 anastomosis, roughly 80%, had a leak that needed a revision. After performing our technique on leaking anastomosis, 141 out of 147 vessels, roughly 96%, were patent 2 hours post-operation. And it is important to note here that our research has demonstrated this technique to be effective in small arterial, roughly 1 millimeter in diameter revisions. But ultimately, we hope that you find our technique of partially occluding arteries with a cotton-tipped applicator to be useful for performing post-anastomotic microvascular revisions. Thank you for watching.
Okay, great. So, now for the revision, do you place the tip applicator if the leak from the posterior side. Not really. We can place the leak and you, I'm sorry, you can place the Q-tip if leak is on either side. It doesn't matter because you actually can rotate the vessel on the Q-tip easily, and you can find where the leak is. The problem with the clamp, when you clamp it, you cannot see where the blood was coming from. With a Q-tip, you can actually manipulate the length of the heights of the occlusion, and you can see where the leaking was coming from. It's very clinical. It's actually very useful. We've been using this for many years. We just published this last year, I think, because it's simple. It's very simple, but it's really effective. Once you clamp it, the blood will stop. By the time you figure out your suture, if you place the stitch, and it might take a few minutes. It's a 1 millimeter vessel. You open it up and it's occluded. So this Q-tip is a good prevention of thrombosis after revision. We're gonna move on. How do we do that? All right, so very quickly, we're kind of exceeding our times until. So this is advanced microsurgery. So this is the course that we teach also for more experienced surgeons who completed the basic or have a lot of experience. They wanted to do different procedures, which is smaller vessels and different free tissue flaps, work with carotids, with the neurografting, we do different organ transplants. So it's basically tailored to the specialties for people who doing much more difficult procedures. So just last week, I had this great guy from neurosurgery, and look at the advanced procedures that he performed. That was pretty cool. So this is carotid bypass that he completed, and it's
Great job. Great antecide carotid bypass using femoral artery with 2 antecides inside the carotid. Great. Done by neurosurgeon, PGY4, who've never done this before.
So this is the guy who was on only 3rd or 4th day of my training. He is in PGY for 4 years on neurosurgery, and then he was very fascinated with the side-to-side anastomosis because this is what they do neurosurgically, and it's not on my curriculum, so we actually practiced that, and I was very happy. Listen what he said. So it was not recorded for this presentation, but it's just very fascinating what he've done.
3. Okay, so what we've done.
So we have your side-to-side anastomosis using 2 running sutures, one on the surface closest to us and another one deep, which you can't see. This is a femoral artery and the femoral vein, and then they're connected here by that anastomosis. You can see the arterialized veins, so it looks like it's working.
So you're using this in the neurosurgery for what?
Side-to-side anastomosis, yeah, we commonly use, in different kinds of complex cerebrovascular neurosurgery. So
amazing. Good job, Jonathan.
So it is.
3.
Oops, sorry. So this is what we do. So this is actually basic, and going back to continuous, this is the only way we use continuous suturing because this is what they do clinically. So, and because the artery and the vein were right there on the rat model, this is why we use those vessels together. Usually they use 2 arteries together, but this was just done for practicing purposes. How do you manage if you find out that you have suture back wall together in front? We revise this. So we taking the stitch apart. When we open the vessel, we look for the patency, and if a vessel is not patent or any stitches that sits deeper in a suture line, we take it out and examine the anastomosis and just revise it. If we are not sure and the vessel is not patent, we cauterize it, cut it, open the lumen and look inside. So we're using that until we figure out why the vessel is not patent. So the surgeons actually learning what they've done wrong, so they prevent that. Okay, so now we're going to have a couple of minutes. So listen by yourself why the microsurgery courses are important. So these people are my students. I recorded that for different purposes, but they're orthopedic, they're plastic, they're from all over the world, and see why microsurgery courses are important. Not from me, but from them. Here they are.
Yes.
My name's Elise and I'm a resident here in New York City in orthopedic surgery. And so I'm taking this as part of my residency program. It's been invaluable so far in terms of coming in with almost no experience with the microscope and now feeling much more comfortable with it, both in suturing vessels and also just in basic tissue handling. I think it's been will be very applicable to my experience in hand and in spine during residency, and I think will be applicable to anything I do just in terms of increasing my dexterity, attention to details, and just working in a field that is so much smaller and somewhat removed from yourself.
Very good. Thank you so much.
Hi, my name's Noah. I'm a surgical resident in Australia, working in Brisbane. I found this microsurgery course very, very useful. I want to pursue a career in plastic and reconstructive surgery, so it's obviously a very vital skill. I think one of the best things about this course is that it runs over 5 days, and so you get lots and lots of time to get lots of practice in and also make lots of mistakes along the way. So you not only learn the techniques of enterocide and end-to-end anastomosis, but you also make mistakes. Like today, I put a hole in the vein and had to repair it before continuing. And I think, that's a very vital skill to be able to translate into the operating room where things don't always go to plan.
So you like when it's it's kind of long, but it's very short in 5 days, very intense also,
Yeah,
and then you repeat.
That's right. I think it's good to, I think the biggest change in my skills were between the second and third day. So having lots of hours to practice and make mistakes, go home and read about what you were struggling with, and then, sleep on it and come back, you improve a lot as you go along.
So you think it's useful for your future career?
Oh, absolutely, yeah. I think it translates. It's not just it doesn't just make you a better microsurgeon, but everyone, who does a lot of microsurgery says it makes you a better macrosurgeon as well.
Very good. Thank you very much. You will recommend this course to others?
Absolutely. Yeah.
Great. Thank you.
Hi, so my name is Max Madu. I'm from Holland and I'm a plastic surgery resident, third year currently, and I'm participating in a microsurgery course. So what I do, I love this course. It's really been helpful because it's really hard at the beginning to handle the fine instruments, handle the fine tissues, work under the microscope, but you see that you progress in the days that follow. So right now I'm really more comfortable than I was at the beginning, starting out with microsurgery. And I just completed my enterocide anastomosis, which I'm very proud. So
I'm going to show you. It's very nice work that Max just did. So you found it useful. And what's the most important thing that you learned so far for the last 4 days?
Well, the most important thing for me, I think, is stay patient, stay calm, don't rush, because you can get frustrated when things don't go your way. And it's really easy to make rough movements and will set you back. So just stay calm and take a little break and then continue on just slowly and you'll be fine. So that's one of the most important things I learned in microsurgery. Don't get frustrated.
That's great.
Because it can happen sometimes.
Of course, and the repetition of the exercise which do not work particularly well is helpful as well, right?
Yeah, definitely. So it's been a very helpful course, definitely.
Very good. So would you recommend this course to your friend?
All right, so I think they all recommend the course, but you can see what are they learning. So different specialties learning pretty much different things. So now with this pandemic, we unfortunately don't have many students coming from different countries. So we're trying to set up a virtual training, as I said in the beginning. So we are trying, this is a trial and error thing. So we bought different gadgets, and what we're trying to do to try to translate exercises that you can do at home through your computer, through your laptop or through your iPad, with the little gadgets that will show you, and translate it basically to me or to other instructors, and have them evaluate you do, and hopefully have a live virtual class. So in the beginning, so this is, again, we are trying to do this. I'll show you how my assistant work with this camera, and you will see what's going on with so she is trying to put the sutures on the glove using this small gadget that we bought for like $30-40 on Amazon. If you're interested, we can send you information, but it's pluggable, right? And it's you can find it online. And what she's doing, she's putting stitches on the microscope, looking through the tablet, through the iPad, and or laptop. And laptop connects through the Wi-Fi. It connects to the Zoom, so she can actually Zoom with this live, and I can look. We practice that. I was looking and annotating on these pictures here below. You can see that I'm annotating. I'm giving her my virtual advice. So she's sitting in the lab, I'm sitting in my office, and I have Zoom on my computer, and she has Zoom on her laptop, and we're working together through this micro scale. So again, but this is, it's a 2D, it's difficult to do, but we're trying to do it with, if you're working with the plastic glove, it probably will be okay. If you're working with the vessels, you might need the surgical loops. So what we're showing you next is my friend Ignacio. So he is a plastic surgeon in Chile, and he developed and he actually published this work. So he is using a chicken model that in his iPhone. So Ignacio Sofentes, he is going to show you on his video. He sent me the video, and we're going to play it so you can see how you can work with your iPhone, a chicken model, and the same recorded, or sending me live your practicing exercise. Not only me, I mean your instructor, your boss, your friend, whoever who can evaluate and work with you. So we're gonna play this video with him. So thank you, Ignacio, if you joined us. Thank you for this video. It's a really great job, and we can
and I would like to share with you my home-based micro training setup. So I think it should be very simple. I use a smartphone for recording my training sessions. Of course, good music. And for augmentation, I use 2.5 loops. Ideally, it would have to be 3.5, but this is what I've got now. So these are my instruments. Yes, the forceps, scissors, and needle holder. And I'm using right now 9.0 sutures, micro sutures. You can actually use all 8.080 sutures as well. And this is just a basic model. I'm just using a plastic bag to do knots. And this is pretty much. So here are some tips. I use a board. I hold a color background below the plastic bag using tape. And for recording, you can have many options. I use this smartphone. I think it's easier to record my session so I can share in this case, iPhone camera app. It can last, it depends on how much space do you have in your smartphone.
I'm gonna
but
double
it
speed
usually
it a
can-
little bit.
It can record up
so
to 30
it's,
minutes or even more. And the thing is, you have to turn on the
I
lights,
hope he
the
doesn't
flashlights.
mind.
So now I'm recording a video here. I can zoom it, as you see, up to 6 times in this iPhone model, which has 2 cameras. But many smartphones nowadays have a lot of zooming. So you can see there how I was doing some knots with 9 zero sutures. And you can see it's actually very
No,
good.
sir.
The thing is, the video is kind of heavy. It's 30 minutes of recording is like 2 gigabytes. So if you want to share, there's another trick I use. And I think this is a very interesting trick, that I have a Zoom meeting between my iPhone and my computer. And then I silence both of them and turn off the camera on the computer. So now I can record the session in the computer with a smaller file footprint, and that can be easily shareable. So I also use a lamp to have a nice view of the training and the working area. But if it's not enough, I use also a headlight loop. I think most of these tools are like the basic equipment of many plastic surgeons. So this is very simple to set up. Now I'm going to tell you what can we do with the latex, the plastic bag model through the recording, through the Zoom. And later on, I will tell you how to do the chicken tight artery anastomosis. So now I'm going to show you the chicken tight model for micro training. Here you can do artery anastomosis, vein anastomosis, and nerve anastomosis. This is the chicken tight. I got it from the supermarket. This was frozen, so you have to unfroze it very gently with tap water, hot tap water. Be careful not to use boiling water because you won't be able to do the model. And as you can see, this is the femur. Here should be the hip of the chicken, and this is the knee of the chicken. Okay, so if you put it in this position, all you have to do is to take this muscle out. Okay, and you will find the vessels here. You will find the vein, the artery, and the nerve. And then you have to cut open wide this muscle, which I have already done, to expose all the vessels, as you can see. So here is the nerve again, here is the vein, and here is the artery. Okay. These vessels are 2 millimeter wide diameter, so are nice to do with 3.5 loops or at least 2.5 loops augmentation. And you can use 8-0 sutures. Hello, everyone. My name is Ignacio Cifuentes.
Okay, great. So now you have idea how to do this at home with the chicken with your iPhone. Thank you, Ignacio. I'm sorry I speeded up your presentation because we're really running out of time. A couple of words of the society that I'm joining, and this is the family of microsurgery educators all over the world, and it's a great opportunity to say hello to everybody from all of us from all over the world. We created a micro e-learning club where you actually can see most of those videos that I presented and contact us on Facebook. So you can see those Facebook clubs, and they connected to the International Micro Club. And IMSS, and directly about setup and different techniques, and we have some videos on it. And then who we are, this is us. This is our society. We are friends, and Centil is a big part of us. And it's originated in London, and I have people from France, and from Japan, and from India, and from Italy, and from Chile, and from all over the world. And IMSS is welcoming you all, and we are really happy to start doing these webinars on behalf of this society. Well, I'm going to thank you for your attention. And again, we have the small chat box, and I think we answered pretty much every question that we have. Or if not, we're going to check the box, that form. And if anybody have more questions, please post this there for a few more minutes with your name, email, and I promise you I'm going to answer everything that you have soon or directly to you. Well, hopefully you have fun. I'm going to stop my presentation, and if there is any more questions, you can please ask me also, so we can say.
Wish us luck. We wish each other luck, and we'll talk soon.
So, well, this is.
Thank you. Thank you, Elena. It's a wonderful presentation as usual. Actually, it's a treasure which keeps on, proliferating, and we could not dig it. What to be extracted from you and what to be left. So every point, each and every tip is, of course, it is parallel going with the clinical application. Whatever you have taught us today is going to play a great role in the clinical application for us. A lot of tips we gained by flipping the vessel wall, preparation of the adventitia, number of sutures to be placed to overcome the post-operative or intraoperative complications. If somebody can do a proper preclinical work like this, definitely he can execute a flawless procedure on the patients. That's what we have understood in all these years, and I'm really proud to be associated with you. And in future, as you mentioned, we can have a lot of online courses at this point of time, so that the pandemic issue will carry out to the next level of our knowledge sharing media in a different way. So with this, I would like to thank for your wonderful presentation, as well as I'm really grateful for the time that you have taken to prepare overall to make the PG trainees to get understood from this. Thanks a lot once again, and thank you, Magadi. Thank you, Savita Dental College, the team, the entire team, Dr. Kadiravan, and special thanks to Dr. Jimson, Dr. Reena, Rachel, John, the Association of Maxillofacial Surgery, Tamil Nadu and Pondicherry chapter, who really supported well with their publication of our brochure to all the media. So that attracted a lot of people, especially PG trainees, to this webinar. And of course, definitely this is a third eye opening for all of us, and we got the real voice from the 20 years experienced gentle lady, Dr. Elena. I'm really thankful once again. Thanks a lot.
You're very welcome. I was really happy to be here. And again, if it's any questions, please guys ask me. And I think I pretty much answer the question as we went along, right? And so we'll do it again. Thank you again. Wonderful to see you all. And goodbye and good luck. Until you can stay on for a little bit.